press conference jointly with my friend and colleague and co-faculty member, Dr. John Jarko, who is the deputy editor of the New England Journal of Medicine. He is also on the faculty at Harvard Medical School at Brigham and Women's Hospital. I specified in my remarks at the beginning of today's LBCT session the relationship between the American College of Cardiology and the New England Journal of Medicine, the fact that the papers that were selected for presentation were done so exclusively by the Scientific Sessions Program Committee of the American College of Cardiology, subsequent to which we partnered with the New England Journal of Medicine, in part related to its 200th anniversary and, as I said, its long-standing tradition of promoting and publishing highly meritorious and novel science. And with those comments, let me introduce Dr. Jarko, who will then introduce each of our speakers in turn. John.
Thank you very much, Pat. It's a great pleasure and privilege to be here today to participate with the ACC in the presentation of this late-breaking clinical trials session. I'd like to thank the ACC and the program committee and co-chairs for enabling us to work with them on this project. So I'd like to introduce one by one the individual speakers who presented at today's session. We'll be hearing them give a brief summary of their work in order, and then after all of the presenters have spoken, we'll have the opportunity to ask questions. So first, Dr. Lamy of the Division of Cardiac Surgery at Canada's McMaster University in Hamilton, Ontario, will be presenting the results of the coronary artery bypass grafting surgery off or on pump revascularization study. So Dr. Lamy.
Thank you. Yes, the coronary trial, the CABG on-pump or off-pump revascularization study. So the benefits of doing beating heart surgery, so doing bypasses when the heart is beating, it's called off-pump, not well established. There was a recent meta-analysis a few months ago which showed that out of 59 trials, most of them were small trials and short follow-up. There was no, out of 9,000 patients actually, the benefits were marginal with stroke, and there's no other benefits in the cardiovascular events. So we did that trial. It's a large surgical trial, but I like to brag it's the largest trial in cardiac surgery. I'm not sure about that, but it's bragging about it. It's 4,752 patients from 79 centers in 19 countries around the world. So this is, they were randomized to on-pump or off-pump. This is what we call a surgical expertise trial. So the surgeon who participated in the trial is actually expert in their technique. They had to be at least a staff cardiac surgeon for 2 years and have done more than 100 procedures they were assigned to. And most of the surgeons at the trial actually were expert in both procedures and have done hundreds of these techniques. The primary outcome was a composite of death among stroke and renal failure at 30 days. We also have another co-primary outcome is the same, plus repeat revascularization 5 years down the road. But of course, we'll have to come back in 4 years from now and present that. There are also neurocognitive function, quality of life, and economic analysis that we're not completed the analysis, so we'll discuss that today. So the results of the trial actually are neutral. So the event rate is 9.8% in the off-pump group and 10.3% in the on-pump group. It basically statistically neutral. We found that off-pump, if we look at secondary outcomes, off-pump will reduce the rate of respiratory infection, respiratory failure, reduce the rate of acute kidney injury, and the rate, importantly, the rate of blood transfusion and reoperation going back to the operating room for bleeding. But counterbalanced by the fact that actually there were more early revascularization by CABG or PCI in the off-pump group. So it's a neutral trial and it's balanced. The benefits are balanced on both sides. From our point of view, these results at 2 days show that both techniques are good and in expert hands the results are excellent and can be done without difficulties. The long term, it will be interesting to see that the differences that we've seen in the morbidity at short term may or may not lead in the future with significant differences in the primary outcome in 5 years.
Thank you very much, Dr. Lyman. Next we have Dr. Harold Litt, who is Chief of Cardiovascular Imaging in the Department of Radiology at the Carleton School of Medicine at the University of Pennsylvania, Philadelphia. Dr. Litt will be presenting the results of the ACRIN PA 4005 multi-center randomized controlled study of a rapid rule-out strategy using CT coronary angiogram versus traditional care for low-risk ED patients with potential acute coronary syndromes.
Thank you for the introduction and thank you for coming. Well, that is a very long title for a study that really has to do with a large public health problem. Chest pain is the second most common reason for visits to emergency departments in the United States, 6 to 10 million per year, and the cost of care for those patients is several $billion per year. Even though most of the patients who come to emergency departments with chest pain will ultimately not be found to have a cardiac cause, that is anything wrong with their heart causing their chest pain on that day, most of those patients will be admitted to a hospital for some type of rule-out evaluation. And that currently is most commonly done by looking at electrocardiograms, EKG, and blood tests to look for evidence of heart attack, performed several times over the course of a 12 to 24-hour stay, followed by some type of stress testing before the patient is allowed to go home. The ACRIN PA 4005 study, which was primarily funded by the Commonwealth of Pennsylvania Department of Health with money from the Tobacco Settlement Fund, and secondarily funded by the American College of Radiology Imaging Network Foundation, was a trial designed to look at coronary CT angiography as a safe and effective and efficient way to evaluate patients who come to the emergency department with chest pain. Patients who fell into the low to intermediate risk category, and that includes people who do not have a previous history of heart disease, were randomized either to a coronary CT-based strategy or traditional care that they would have received at that institution. And we randomized twice as many people to the coronary CT arm as we did to the traditional care arm. The reason for this randomization and the number of patients that we enrolled is that the primary goal of this study was to demonstrate the safety of the coronary CTA approach, and specifically to show that patients who had no significant coronary artery disease on their coronary CTA and were discharged from the emergency department had a less than 1% rate of major adverse cardiac events, which includes heart attack and cardiac-related death at 30 days. We were looking at defined significant coronary disease as stenosis in the coronary arteries, that is an area of matter or blockage, more than 50%. So patients who had no evidence of stenosis of more than 50% on their CT, we wanted to prove that in 30 days, their rate of heart attacks or cardiac-related death was less than 1%. There have been previous studies that have looked at coronary CT in the emergency department, including some smaller randomized controlled trials, but none of them had enough patients to be able to prove statistically that the CT approach met that safety threshold. And this is important because emergency department physicians want to feel confident that when they send somebody home after a rule out by a heart attack evaluation, that those patients are going to be safe and have low rates. We enrolled about 1,400 patients, 900 or so in the coronary CT arm, and 462 in the traditional care arm. In the coronary CT arm, not all of the patients ended up having coronary CTs because we left a lot of the decision-making up to the doctors in each individual institution. This study was performed at 5 different sites, 4 of them in Pennsylvania, 1 in North Carolina. About 16% of the patients who were randomized to the CT arm ended up not having the most common reason for that was that patients had a heart rate that was too high to allow them to get a coronary CT, and that was 27% out of those 16% of patients who didn't have it. The next most common reason was that the doctor who was caring for that patient at the time that they were going to get the coronary CT decided that they no longer needed it. So they may have been seen by one person and initially felt that they needed to be entered into this trial and randomized to coronary CT, but at some point later, that physician or another decided that they needed it. Compared to the traditional care arm, which again was half as large as the coronary CT arm, we looked at how many patients ended up having each test, what types of tests did they have, how many underwent cardiac catheterization, what were their event rates at 30 days, and then some other resource utilization aims, including how often did they go back to the emergency department, how often did they go see a cardiologist, how often were they taking various medications, and how often did they undergo various procedures. So with respect to the primary aim, we were able to show that in the 640 patients who had what we defined as a negative CT, that is one not showing any stenosis more than 50%, 0% of them had a myocardial infarction or cardiac death at 30 days. And statistically, the upper limit of that confidence interval, which is the measure that statisticians use, was 0.57%. So we were able to show that our primary outcome was true, that a negative coronary CT means that we can safely discharge someone and that their 30-day event rate was less than 1%. Comparing the two arms, they had similar rates of heart attack, about 1% in each, similar rates of total incidence of acute coronary syndrome, similar rates of cardiac catheterization. Importantly, in the CT arm, 76% of the cardiac caths were positive, compared to the traditional care arm, where a lower percentage of caths were positive. So CT was identifying patients who needed their cardiac caths more than traditional care did. Sure. So we're going to look at these, so to conclude, we met our primary aim in showing the safety of a coronary CT approach. We also showed decreased length of stay. Patients stayed in the emergency department for less time, and they were more likely to be discharged if they were in the CT arm versus the traditional care arm. We need to follow up out to 1 year to look at their future resource utilization in terms of doctor visits and future events to see whether this remains a cost-effective and safe technology. Thank you.
Thanks very much, Dr. Litt. And now go next to Dr. Harold Roger Lula, who's Professor of Vascular Medicine at the Academic Medical Center in Amsterdam. Dr. Lula will be discussing the EINSTEIN-PE study, oral rivaroxaban alone for symptomatic pulmonary embolism. Dr. Lula.
Thanks very much, Dr. Yoga, and thanks very much for the invitation. The disease I'm talking about is venous thromboembolism, which actually happens to be the third most common cardiovascular disease. First is myocardial infarction, second is stroke, and third is venous thromboembolism. It occurs with a frequency of about 2 to 3 patients per 1,000 inhabitants each year. My last statistics is one of my favorites, is that if I go to a family gathering, birthday, and so I'm interested in venous thromboembolism, I'll always ask me, where are the drinks? If I say I'm interested in AIDS research or traffic accidents, then they want to talk to you. I'd just like to remind you that each year in this country, more patients die of pulmonary embolism than actually a combination of traffic accidents, breast cancer, prostate cancer, and AIDS together. And therefore, let's say different agencies have really pushed the point is that this disease is really need to look after it. Now, of course, if you have the disease, you need to be treated. And the Einstein pulmonary embolism study tried to make the treatment of these individuals with pulmonary embolism, which are clots in the lungs, easier. Nowadays, if you have a pulmonary embolism disease confirmed, You're put in a hospital, you either get an intravenous pump with heparin, or you get injections with low-molecular heparin for 5 to 10 days. And you start on warfarin. And then the warfarin, I'm sure most of you are very familiar with that, is then very carefully monitored. What we did in the Einstein pulmonary embolism study is use a novel approach, which is rivaroxaban, which is oral 10A inhibitor. We figured out how much we had to give in those finding studies. And the bottom line is, we decided to give for the first 3 weeks a more intense dose, 15 milligram twice a day, so 2 pills a day for the first 3 weeks. And then at 3 weeks, we switched to 20 milligram once a day. And this one was compared to standard treatment in more than 4,800 patients. What are the conclusions? We set out to show that it is at least as effective. And the term is non-inferiority, but it basically means that you and I will come to the conclusion that the risk of recurrence, that's why we treat these patients, the risk of getting a second, third event of venous thrombosis was completely identical with the two groups. Second is we had to hope that we would see less bleeding. Every anticoagulant causes bleeding. And so we carefully follow these patients for major bleeding and for clinically relevant non-major bleeding. If you combine the two, they were actually same rates. If you look carefully at the major bleeding, which is the ones we really hate, not only physicians but patients too, is there was a statistically significant 50% reduction in major bleeding. And then finally, this study was undertaken that there is an increasing awareness that this disease, venous thrombosis or pulmonary embolism, actually could be treated outside of hospital. Maybe a patient needs to be in hospital for 1 day to be observed, but it is not necessary to have these patients in hospital for 5 to 10 days, as has been the practice. So therefore, we wanted to make this regimen very simple. We believe with 2 pills in the first 3 weeks, no monitoring, no dose adjustment, and then 1 pill for the remainder of the time, 3 months, 6 months, 12 months, 2 years treatment. And then in conclusion, this is the Einstein-PE study, which indeed is published today in the New England Journal. In 2010, the Einstein deep vein thrombosis study, which are sister trials, was also published in the New England Journal. If we look at them together, they're very consistent. And I think they reassure us that for patients with venous thromboembolism, we now can offer both physicians and patients an attractive alternative of a single drug approach. With that, I stop.
Thank you very much, Dr. Doolittle. And our last presenter is Dr. Susheel Kodali, who is co-director of the Heart Valve Center at Columbia University Medical Center and New York Presbyterian Hospital. Dr. Kodali will be discussing valve replacement results from the high-risk cohort of the partner trial.
Thank you. So just to sort of set the backdrop, aortic stenosis is a disease that in the U.S. at least typically affects the aging. The incidence goes to about 10% after the age of 80 and about around 4% after the age of 70, is variable depending on the studies. The disease is calcium deposits on the aortic valve which cause it to narrow. And over time, once it continues to progressively narrow, patients get symptoms of chest pain, shortness of breath, or dizziness. If you don't, once the patient has symptoms, if you don't fix it, the prognosis is poor. The prognosis with untreated aortic stenosis is worse than most cancers. 5-year survival is typically less than 5%. So the standard treatment for aortic stenosis is surgical AVR, and that's been well established and it works very well. It's been done for decades, and the surgeons have been doing it very well. But there's numerous studies that anywhere from 30 to 50% of patients with severe symptomatic aortic stenosis do not get treated. The most common reason is either patient refusal, patient's too sick, or they're just not candidates for surgery. So transcatheter AVR is a treatment option that was the first device was implanted in April of 2002. Since then, several devices have gotten approval in Europe. The device we're studying in this trial is the Edwards sapien valve. And basically, it takes a tissue valve similar to what the surgeons would sew in when open heart surgery, opening the chest, stopping the heart, taking out the diseased valve, and suturing in a new one. This device takes the same valve, puts it on a stent, It's inserted through the groin, it's positioned and deployed. So essentially a new valve is implanted through the groin or through a small incision in the left chest without stopping the heart, without going on bypass. The high-risk cohort randomized patients that had a surgical risk of at least 15% between conventional surgery and transcatheter valve replacement with the Edwards-Sapien valve through either the transfemoral or transapical. The one-year result, which was a primary endpoint, was presented last year at ACC, and the current study presents the 2-year results. The reason this current study is important is we want to establish that the valve is durable, that this is not a short-term benefit, because we need to prove that we're equivalent to surgery in terms of valve durability, that the valve is not going to degrade over time, that there aren't late complications. Any new therapy, you've got to verify there aren't late complications. So this trial randomized those patients between surgery and transcatheter. The primary findings of the 2-year analysis is that over longer-term follow-up, out to 36 months on Kaplan-Meier curves, all patients reached at least 2 years. There was no difference in mortality, cardiovascular mortality, and New York Heart Association class between the two groups. One of the concerns that was presented last year was stroke. With this procedure, because you're manipulating the valve and you're not opening the chest and potentially stopping the heart, there was a higher risk of periprocedural strokes. And one of the concerns is in longer-term follow-up, without removing the diseased valve, we're going to have more strokes later. And what we see here is there's no late hazard for stroke. After that initial risk, there's no late hazard for stroke. Such that over the course of the trial, there's no difference in stroke events between the two groups. The other findings that we're looking at are, is there evidence of late valve failure, endocarditis, or infection, because it's a turbulent system? Are there valves that deteriorate and need surgery? There's no evidence of that either. Do we maintain functional improvement? Surgery works very well. The reason we operate on AS is people not only live longer, their quality of life improves dramatically. And we get the same improvement in functional status out to 2 years in both groups. One of the interesting findings of this study is that we were looking at predictors of mortality. I showed some of the big predictors in the multivariable analysis, but one of the more interesting ones is the impact of paravalvular or aortic regurgitation. Because we're not removing the valve, there's potentially you're not going to seal, and you would get leak around the valve back into the heart. And the question is, that the severity of paravalvular regurgitation has been seen with transcatheter valves in multiple studies. Over 50,000 patients have been treated with different devices worldwide. And in general, most of the studies show that the presence of moderate to severe paravalvular regurgitation is anywhere from 10 to 12% in most studies, and mild is at 40% or so. So we saw the same. There was no change in the severity of paravalvular leak or regurgitation over the course of the study. But what we did see is patients that had paravalvular regurgitation or aortic regurgitation in general had worse mortalities compared to those that had none or very trivial leak. So, and I think that's an important target for us to address. Longer term, if we can reduce these events and complications, we may have a lot better outcomes than we have right now. And I think this is an early stage trial, and we want to look at longer improvements to the field.